physician. Today my talk is actually two parts. The first is the brain tumors, about the brain tumor, and the second part is multi-parametric imaging, as the, for example, PET MRI images of in oncology. And I will start the first part, brain tumor. I divided the presentation for several parts. The first is overview of brain tumors, and the second is radiopharmaceuticals for brain PET, and the usefulness of pre-treatment brain PET, and the most importantly, the assessment of tumor recurrence in, and finally, the briefly comment the image analysis of brain PET. Brain tumors affect approximately 5 to 10% per 100,000 populations, and the primary tumors and metastatic tumors are 50% to 50%, but actually the metastatic tumors are more common than the primary tumors. In children, brain neoplasm accounts for up to 20% of all cancers, and the most widely accepted system for classifying brain tumors is the WHO classification, which you know very well, of tumors of the central nervous system, which is based on the histological characteristics of the tumor. There are very many types of brain tumors, so I cannot discuss about all of them, but many brain tumors can be divided into 4 grades: 1, 2, 3, and 4. For example, BYUN, glioblastoma multiforme, is considered as grade 4, which is very aggressive tumor. It is high-grade tumor. And more than half of brain tumors are brain metastases. And lung cancer, breast cancer, and melanoma are the most common primary malignancies that metastasize to the brain. But as you know, many other types of cancer can metastasize to the brain. And meninges are also a frequent site of metastatic disease involvement. From now on, I will talk about the radiopharmaceuticals for brain imaging in cancer. FDG, F18 FDG is the most commonly used radiopharmaceutical, as you know, in oncology. So it is also used for brain imaging in brain tumor. It is an analog of glucose, and it reflects the metabolic activity of the structure. But normal brain parenchyma also shows a high activity, as you know well. So it is a drawback of F18 FDG in brain tumors. As you can see in this image, on FLAIR image, there are some lesion which is suspected as some tumorous lesion. Actually, the patient had a low-grade glioma. A low-grade glioma usually shows a little metabolic activity than the high-grade glioma. So you can see significant hypermetabolic lesion on FDG PET, right? And actually, there may be some uptake, but we cannot differentiate the uptake with the normal brain parenchyma on FDG PET. It is a drawback of F18 FDG PET in brain tumors. Sorry. So many researchers have studied other radiopharmaceuticals for imaging the brain tumors. One of the example is amino acid PET. Mm, the examples of amino acid PET agents, radiopharmaceuticals are C11-methionine, but the half-life of C11 is relatively short. It's about 20 minutes. So the usefulness of the methionine PET is somewhat limited. So F18FET or F18F-dopa was used as a amino acid PET agents. They reflect the expression of amino acid transporters in transformed cancer cells. And usually normal brain parenchyma shows little uptake of amino acid PET agents. As you can see in this image, this slide, this image is an image of a 49-year-old woman who had been previously treated for GBM with tumor resection and conventional radiotherapy. During follow-up, there was an enhancing lesion on MRI. So we can suspect tumor recurrence. On C11-methionine PET imaging, you can see a significant increased uptake at the corresponding area on MRI. So it is very useful for assessing the tumor recurrence in brain tumors. Another radiopharmaceutical is F18FLT. F18FLT is retained in proliferating tissues by the action of thymidine kinase 1. And FLT is the thymidine nucleoside analog. So on FLT PET, normal brain parenchyma usually shows little uptake because they are not so much proliferating tissues. So it is very useful for differentiating tumors and non-tumorous regions. For example, on this image on MRI, the patient was treated with tumor resection, and there was some enhancing lesions around the resection margin, and so clinicians suspected the tumor recurrence at this site. But you cannot significant hypermetabolic lesion on FDG PET. Actually, there may be some uptake, but it was not differentiated from normal parenchymal uptake. However, there were significant increased uptake in FLT PET, on FLT PET. So someone may think that this is a tumor recurrence, but actually, this region was pathologically confirmed to be a radiation necrosis. It was not tumor recurrence. Although we studied many MRI and many radio tracers of brain PET, we could not accurately, perfectly differentiate the tumor recurrence and radiation necrosis. So I will discuss later about that, but I think that use of MRI and many radio tracers, the combination of these modalities are needed to improve the diagnostic approach. And the next part is pre-treatment PET in brain tumors. I divided the subject into four categories. First is the differentiation of tumor and non-tumor, and the grading of brain tumors, and the prediction of survival, and RT planning, radiotherapy planning. Before treatment, it can be sometimes difficult to differentiate the tumorous region and non-tumorous region, because many regions can be enhanced on MRI. For example, tumor, abscess, cystic sarcosis, hematoma, etc. As you can see in this image, there is a cystic region and somewhat enhancement around the rim. But FDG PET did not show significant uptake around the cystic region. And methionine PET also did not show significant increased uptake. And actually, the lesion was confirmed as cystic surfaces, and it was not tumor lesion. So sometimes PET may be useful for differentiating tumor and non-tumorous regions. This is another example. There was a suspected tumor lesion. I cannot see well, but there was some suspected lesion on MRI, and but there was no uptake, no significant uptake. But there was some focal metabolic defect at the corresponding area. Actually, this lesion was focal cortical dysplasia, developmental abnormality. So maybe this region will not function well. So sometimes pen may be useful for differentiating tumor and non-tumorous regions, but there are some overlap between tumor and non-tumorous region, especially the inflammatory brain regions. So it has some limitations. Another application of pre-treatment PET in brain tumors is grading tumors before surgery. For example, FDG PET is useful. As I mentioned before, high-grade brain tumors show high FDG uptake because they shows a high metabolic activity. Otherwise, on the contrary, low-grade brain tumors show low FDG uptake because they show little metabolic activity. And but what is the definition of a high or low FDG uptake? It is very simple. We can say that if the region shows similar uptake as white matter, we can suggest that the tumor is low grade. It shows little metabolic activity. But when the tumor shows similar uptake or higher uptake than the gray matter, we can suggest that the tumor is high grade, which means grade 3 or 4. For example, there is increased uptake at this lesion. Actually, the tumor was grade glioblastoma, grade 4 high-grade brain tumor. Compared with the normal brain parenchyma, there was increased uptake. So it was a high-grade brain tumor. On the contrary, we cannot significantly increase the metabolism in this scan, but you can suspect some lesion here. Actually, the tumor was at this side, and the tumor showed similar uptake as a white matter. The tumor was grade 2 oligodendroglioma. So, on visual analysis, we compare the tumor uptake with the normal parenchyma, white matter, and gray matter. Then we can expect the tumor grade on average PET. Another application is the prediction of survival. As you can see in this graph, the patients with brain tumors with higher FDG uptake showed poor prognosis than the patients with brain tumors with low FDG uptake. There are many research that the FDG tumor uptake is useful for the prediction of survival because high FDG uptake is associated with a poor prognosis. And the final application of usefulness of the pre-treatment path is the radiotherapy planning. Integration of a path in neurosurgical procedures may contribute to a better management of brain tumors, either in optimizing their delineation or in targeting the aggressive areas of heterogeneous tumors. As you can see in the left image, we can, this is an FDG pad, FDG brain pad. You can see hypermetabolic lesion here, the tumorous region, and you can draw the region of interest according to the metabolic activity. For example, blue line shows the tumor region with a higher FDG uptake than the surrounding tumor regions. Then we can combine this region of interest with the MRI. On the co-registered images, we can define the area with the high FDG uptake. After the co-registration of FDG PET and MRI, we can apply this imaging for the radiotherapy planning. Nowadays, IMRT, intensity modulation radiotherapy, is widely used. IMRT is defined as the intensity modulation according to the tumor region. For example, we draw the tumor region with a high FDG uptake. We can think that this region shows a higher metabolic activity than the rest of the tumor region. Then we can give more energy to this side according to the FDG uptake. It is very reasonable and it can be very useful. But in clinical practice, it has a critical problem because nowadays, usually radiotherapy is composed of fractionated radiotherapy, right? But FDG PET is performed just before the treatment, not after each fraction of radiotherapy. So, for example, after the first fraction of radiotherapy, the distribution and the size of tumors significantly change. Right? So this map cannot be applied to the second or third fractionated radiotherapy. So nowadays it has a critical problem for clinical use. I hope someone to solve this problem, but it is very reasonable. If we scan FDG PET on each time on the fractionated radiotherapy, it can be possible, but it is not possible because of the cost, and it is not possible. So someone may solve this problem, I hope. And the next part is the assessment of recurrence. Actually, this is the most important application of brain PET. Differentiation between recurrent brain tumors and radiation necrosis is often difficult with conventional diagnostic imaging techniques such as MRI, because as you know, during the follow-up of brain tumors after the treatment, surgery or radiotherapy, the region can show enhancement, although it is not in a recurrent tumors. Radiation necrosis can also show enhancement on MRI. For example, you can see enhancement on MRI after the treatment. On FDG PET, there was a significant increased uptake here. And on methylene PET, also there was an increased uptake. And Therapeutic PET also showed increased uptake. If we meet this situation, we can say that this is a high probability of recurrent brain tumor. But when we see these images, these images, we can think differently. On the left side, this is an image of a 49-year-old woman who had been treated for GBM with tumor resection and radiotherapy. There was an enhancing region, and there was an increased uptake on methionine pen, very high uptake compared with normal brain parenchyma. So we can suggest the tumor recurrence at this site. In the on right images, this is an image of a 25-year-old man who had been treated for anaplastic astrocytoma with tumor resection and radiotherapy. There was an enhancing region. There was an increased uptake, but the activity is somewhat lower than this. There was just a moderate uptake on methionine PET. Actually, this region was confirmed as gliosis without tumor, so it was not tumor recurrence. So it is important to define the activity of this site. Actually, I will discuss about it later. So quantitative analysis as well as visual analysis is needed to differentiate tumor recurrence and radiation necrosis on the methionine pad or other FFT pad. I summarized the diagnostic accuracies of MRI and PET for the diagnosis of brain tumor recurrence. Actually, there are many reports about the diagnostic values of MRI or PET for diagnosis of brain tumor recurrence. When we summarize these studies, which includes about 400 patients, the sensitivity of MRI for diagnosing brain tumor recurrence was about 90%, but the specificity was very low, about 50%. But some reports say that it's more than 60%. Anyway, MRI shows a relatively low specificity for diagnosing brain tumor recurrence. So PET is useful for the diagnosis of brain tumor recurrence because they show higher specificity than MRI. Based on meta-analysis, activity PET showed 77% sensitivity and 78% specificity. Similarly, serum methionine PET showed 70% sensitivity and more than 90% specificity. And FLT PET showed 82% sensitivity and 67% specificity. Personally, I think that FLT PET shows a higher sensitivity than other PET tracers because of lower uptakes of normal brain parenchyma. Anyway, we can say that MRI shows a higher, lower sensitivity, specificity, but higher sensitivity. And PET shows higher specificity than MRI, but somewhat lower sensitivity than MRI. According to this data, we can think that the combined use of MRI and PET is needed to improve the diagnostic accuracy in brain tumors. This is a case in our institution. Actually, the patient was treated with concurrent chemotherapy and radiotherapy 2 years ago for GBM, high-grade tumor. During follow-up, there was an enhancing lesion on MRI, the size is not so large, but it is suspected. And FDG PET did not show significant increased uptake at this site, but FET PET and FLT PET showed focal increased uptake at this region, and the region was confirmed as recurrence. Yes, in from these images, we can say that if the MRI and PET tracers are combined, we can we can suggest the tumor recurrence or radiation necrosis more confidently. The final part is the image analysis. When we look at these images, there is a focal uptake, focal increased uptake on FET PET, amino acid PET, and FLT PET here. Based on the visual analysis, we can say that there is a increased uptake. There is an increased uptake. But when there is a moderate uptake, can we say that it's recurrence or radiation necrosis? So we need quantitative analysis. Yeah. Usually, for the diagnosis of brain tumors using FDG PET, visual analysis is useful. We can compare the activity with the normal tissue. However, on FET PET and FLT PET, normal brain parenchyma shows very little uptake. Sometimes there is a breakage of blood-brain barrier on the around the tumor resection site or radiation site. At the time, FET or FLT can accumulate at the site with breakage of blood-brain barrier. At the time, it shows a moderate or somewhat increased uptake. To differentiate the moderate uptake and the high uptake of recurrent tumor, we need to quantitative analysis. For example, we draw a region of interest here, a red circle. This is tumor region. Then we draw a region at the surrounding area, surrounding normal brain area. Some researchers draw the blue circle on the contralateral frontal area, but some others draw the circle around the tumor. Yeah. Anyway, we can measure the SUV max of tumor and SUV mean of the normal brain. Then we can calculate the ratio of SUV max of tumor to SUV mean of normal brain. If the ratio is higher than 1.4 or 1.5, we can suggest tumor recurrence. If the ratio is less than this cutoff value, radiation is more likely than tumor recurrence. Up to now, it is the best way or the most commonly used way for the quantification of tumor uptake on FET PET or LT PET. Actually, the diagnostic accuracy of previously reported studies on the methionine PET and LT PET or FET PET are based on this method. Okay, finally I will show a case with PET MRI on brain imaging. We can combine the PET imaging and MRI. Then we can see the diffuse the image. On MRI, there is an enhancing region, and on FET PET, there is an increased uptake. When we combine the co-register these two images, we can say that this increased uptake on FET PET corresponds to the region on MRI. So it can be helpful for the diagnosis about PET MRI and multiparametric imaging. I will talk about the second part of my presentation. And yes, this is summary. There are usually there are three kinds of PET. Actually, other tracers are also available, but I showed three kinds. The first is FDG. It represents the metabolic activity of brain tumor. And amino acid PET, it shows the amino acid transport activity. For example, C11 methionine PET, F80 PET, and F18 epitope. Finally, F30 PET. It shows the TK1 activity, thymidine kinase 1 activity. So the F30 PET, shows the proliferation of the brain tissue. By using FDG PET, we can inspect the tumor grade compared with white matter and gray matter. If the tumor shows higher uptake than the gray matter or similar uptake to the gray matter, we can suggest the tumor is high grade. And high FDG uptake is associated with poor prognosis. And the radiation necrosis and tumor recurrence is the most important indication of brain PET. Based on the previous reports, the sensitivity is higher on MRI than PET, and the specificity higher on PET than MRI. So personally, I recommend the use of PET and MRI for the diagnosis of the brain tumor recurrence. When we use amino acid PET or FLT PET, we can calculate the tumor to normal brain SUV ratio, and the cutoff value is 1.4 or 1.5. That's all. Thank you for your attention.